Hi everyone, my name is Jay. I'm one of the advanced practitioners. Today we are going to discuss a case study looking into neurology referral from primary care to secondary care. And basically, it's more about a delayed diagnosis of a motor neuron disease presenting at the primary care first contact practitioner clinic. So, we're going to discuss the study in a STAR format, which requires situation, task, action, and result. We're going to call our patient A. They are in their late 60s, and this has been discussed as a formal complaint. So we're going to look at the situation. So patient presented with the symptom to the primary care clinician at the GP surgery. Before presenting to the GP, they had the symptoms for about a year or so. And initially the patient presented with the low back pain and left lower limb weakness. The main symptoms were weakness in the left lower limb, developing foot drop, slapping the foot to the floor, cramps to the legs and abdomen, struggling to walk but also struggling to walk uphill, muscle flickering in torso, legs and arm. His speech, swallowing and respiration was fine. There was no issue with them. When the GP saw him, an MRI scan of the lumbar spine was organized because patient's family member was a healthcare professional and they informally assessed him and flagged it up to be formally assessed by a healthcare professional. So, as mentioned, the patient was seen by the GP. GP has organized an MRI scan and referred to first contact physiotherapist in the primary care clinic. FCP identified the foot drop and lower limb weakness. When the patient presented, they were not complaining of the pain. They were not complaining of any numbness, pins and needles, or any saddle anesthesia or any systemic symptoms. It was pure the left lower limb, unilateral left lower limb weakness, wasting, and foot drop, inability to do the heel raises. The FCP identified this and presented to the spinal MDT. Spinal MDT informed there is no correlation between the patient's symptoms and MRI. Advised to do an MRI in knee, looking into the tibial nerve around the head of the fibula or any cyst or any lesion which is compressing the nerve. Also advised to do EMG and nerve conduction study to ensure the appropriate nerve conduction and muscle function. Patient did not have any other comorbidities apart from having a right rotator cuff repair about few years ago, which is in 2017. The spinal MDT informed to do an MRI scan but also refer the patient to neurology. Patient was referred to neurology, informing that the patient has been reviewed at spinal MDT and it was suggested to refer to neurology. Despite this, neurology has rejected the referral. So we're looking at the task at the hand, what needed to happen and what gaps existed. So looking at the clinical responsibility, we have to ensure the progressive neurological symptoms received specialist review. Coordination between GP, FCP, spinal MDT and neurology is there. Prevent diagnostic delay in a potentially time-critical illness. Maintain clear clinical ownership across the pathway. System responsibility. Define transparent neurology referral criteria. Communicate referral criteria to primary care professionals as well as allied health professionals. Ensure rejected referrals included an alternative pathway. Resolve cross-specialty responsibility gap. The patient-centered responsibility. Inform the patient of the diagnosis in a timely, compassionate way. Provide access to MND, MDT, support from the point of diagnosis. Offer psychological, neuropsychological support early. Ensure DVLA benefit and eligibility advice is given. A key gap identified here was no one in the primary care, FCP, or ED knew the neurology referral criteria, but also they were unable to reach the neurology team when it was required, creating a harmful circular pathway with no clear ownership. Coming to action, so as mentioned, most of the healthcare professionals, they acted very promptly and swiftly, and within their scope of practice they did the right things in terms of diagnosing and referring the patient, but also escalating in a timely manner. So GP saw the patient with the back pain and some limb weakness, organized MRIs, referred to the FCP noticed the lower limb weakness and foot drop, and taken to spinal MDT with the MRI report. Spinal MDT informed appropriately that the patient's symptoms are not correlated with the spine, advised further investigation in terms of nerve conduction study, EMG, and further MRI of the knee around the tibial nerve. Informed the patient needs to be referred to neurology. Patient was referred to neurology, but it was rejected. Patient was frustrated and his symptoms were progressively getting worse, so they were sent to ED, or emergency department, accident and emergency. Patient was seen by the healthcare professional over there, but ED was unable to diagnose. They tried reaching the neurology team but could not reach them, so discharged with the suspected autonomic neuropathy. Patient was frustrated and not sure how to help himself or themselves. So they requested that they're happy to see a private consultant, but wanted to know which specialty they should see. They were advised the neurology specialty, and they saw a private neuroconsultant who diagnosed them clinically having motor neuron disease and ALS. The private neuroconsultant also referred the patient to the local neurology service urgently, and patient was seen by the local neurology team, offered MDT, seen by the respiratory consultant, neurologist, and offered the support of the MND nurse and MDT support. In terms of action, what should have happened? Referral should have been accepted by the neurology, and that was the appropriate pathway and shouldn't have created this problem of referring back and forth patient to different specialties. Spinal MDT had already reviewed and excluded spinal pathology, clinical indicators of foot drop, upper motor neuron lesion, lower motor neuron lesions, and signs of vasculations warranted urgent neurology referral. Rejection created a clinically dangerous feedback loop, and rejecting clinicians should have provided an alternative pathway. Referral criteria must be transparent. GPs, FCPs, and physios and ED clinicians had no access to neurology referral criteria. Criteria must have been published and communicated to all referring settings. Complex mixed presentation, spine, neuro needed a defined escalation route. Rejected referral must include a named alternative time frame. Interspecialty coordination required. Neurology, spinal surgery, orthopedics, and ED must have a shared pathway. Clinical lead should be assigned for cases cross specialty. MND pathway should be triggered from the point of clinical suspicion, not confirmed diagnosis. And early MND nurse contact reduces patient psychological harm. So interspecialty coordination really required for this patient. What the result was, an impact on the patient. Of course, patient was distressed and frustrated, but also had a life-limiting diagnosis. Attendance to the A&E was inappropriate, but also discharged without diagnosis or plan once they were sent there. Profound psychological harm. Patient felt that the future and life has been taken away. Had to fund privately to see a consultant to get a diagnosis, and delayed access to MND nurse, neuropsychology, PIP, DVLA, and medications. Had an ongoing delayed diagnostic delay distress. System failure exposed. There was no published neurology referral available. no cross-specialty escalation pathway established. There wasn't any ongoing interdisciplinary collaboration or joint clinics or MDT. Circular referral loop with no resolution, no single point of clinical ownership. Current status aimed at the time of complaint. Patient was under the care of local NHS trust, had a support of the MDT, including various specialties and MND nurse. Blood gases were normal, lung function and sleep study was organized. Neuropsychology support offered PIP and DVLA support. Follow-up is scheduled with a consultant. So a complaint was formed and escalated to the chief medical officer. Response requesting within the appropriate time frame. Review of the neurology referral rejection decision. Publish clear neurology referral criteria and written apology to the patient. The key learning point was that rejected referral must always include an alternative pathway. Never leave a patient in a clinical void. Neurology referral criteria must be published, accessible, and proactively shared with all referring teams, including primary care, FCP, and ED. Whereas spinal MDT has already reviewed a case, recommended neurology, this constitutes sufficient grounds for acceptance without retriaging to spine. MND pathway activation should begin at point of clinical suspicion, not confirmed diagnosis. Delay causes irreversible harm. Interspecialty coordination, neurology, spinal, orthopedics, and ED requires a named clinical lead for complex presentation, crossing specialty boundaries. I hope this has been helpful to understand the presentation of the neurological condition, especially MND at the FCP clinic, and how to escalate. Thank you for listening.